and we are being recorded. We ask that you do not include any confidential patient health information during this session, particularly during any case consultations. I don't believe we'll be doing any of those this morning. On screen is information on how to connect to audio if you haven't already, and I think we have everyone on so far who needs to be. Do not place us on hold, please, or everyone will hear your hold music and I'll have to mute you. *6 will mute and unmute your phone if you need that code. We also ask that you enable your camera so you can join the discussion and everyone can see each other. You can see our camera is enabled at this point and yours is as well. You just have to click the camera button and then start my webcam after you've previewed it. Our disclosure and accreditation statements are on the screen now. And here's a slide about case consultation reimbursements. This is for our other sessions that we do. If you're interested in this, for doing a case consultation with a patient with Molina or Blue Cross Blue Shield New Mexico Centennial Care, then please contact Michelle Widener, who is on a slide at the end of this slide set. And now is, in fact, we've basically already done roll call. This would be the time to do it. But we do have Julie Fitzgerald, Tiffany Kinter, and Megan Lusick on, and I see Daisy Rosero is on as well. So if anyone else would like to state their names, please do so at this point. And you can do that through the chat box or over audio. And I think we have everyone on audio. Okay, I think we have everybody. So please welcome Timothy Condon, PhD, who will be presenting for us today.
Well, good morning, all three of you. Thanks for joining us this morning. As Kevin said, I'm Dr. Tim Condon. I'm a research professor at the Center for Alcoholism, Substance Abuse, and Addictions at the University of New Mexico, working with Envisions and the Department of Health on this SBIRT project. This project has been made possible by a generous grant from the Conrad and Hilton Foundation, and we're very pleased to be doing this project in the state of New Mexico, and I hope you will be too. So New Mexico School-Based Health Center partners are the New Mexico Department of Health School-Based Health Center program, which is located in the Office of School and Adolescent Health, the University of New Mexico Center for Alcoholism, Substance Abuse, and Addiction, where I'm a research professor, Envision New Mexico, where we have a number of people, Daisy Rosero, who is on the other line, and Dr. Mary Ramos, who is part of the Department of Pediatrics. As I said, this is made possible by a generous grant, 3-year grant from the Conrad and Hilton Foundation, who are particularly interested in extending the reach of SBIRT and adolescent programs throughout the country. And we have as our partner, especially for this SBIRT presentation, the National SBIRT ATTC, which stands for Addiction Technology Transfer Center Network, and that's funded by the Substance Abuse and Mental Health Services Administration. If you just type in ATTC network, you'll find the one ATTC that specializes in SBIRT, and they have lots of pre-recorded information and presentations and a lot of the material that you'll see today. So New Mexico School-Based Health Center program, as you probably know, there are over 50 Department of Health funded SBHCs in New Mexico. Most are located in secondary schools, high school or middle school, although there are a few K through 12 and elementary schools. One of the beauties of New Mexico's program, and especially school-based health centers in general, is that they provide an integrated care model, and that's what all of medicine and all of healthcare is moving towards, is the integration of both primary care with behavioral health. And in New Mexico, all school-based health centers have typically a primary care provider, either a nurse practitioner, a physician's assistant, or in some cases actually a physician. And they also have a master's level counselor or therapist, a behavioral health therapist. And this is really the model that should be really introduced throughout the nation. Most are open several days a week, as you know. New Mexico School-Based Health Center program services include sports, physicals, wellness exams, care for acute illnesses, injuries, ongoing care for pediatric obesity, overweight, or for asthma. And of course, some of the more confidential services that the centers are known for are for sexual and reproductive health and for behavioral health issues that we're addressing here today. The background for the initiative is that New Mexico has a tremendous adolescent drinking and substance abuse problem that's probably not a surprise to most of you who are practitioners out there. School-based health centers are incredibly well positioned to be able to address this public health problem. New Mexico Department of Health School-Based Health Center program is incorporating SBIRT, screening, brief intervention, referral to treatment, into its standards and benchmarks for SBHCs beginning this year in 2015. So this is actually going to be part of those standards and benchmark from here on in. Substance use rates among New Mexico and U.S. high school students in 2003 from the CDC Youth Risk Behavior Surveillance Survey shows that really some very disturbing information. Alcohol use, again in the first column, alcohol use before the age of 13 years of old nationally is 18%. In New Mexico, it's higher at 22.3%. Marijuana, again, before the age of 13 years old, nationally is 8.1%. And here in New Mexico, we have 2.5 times as high as 17.3%. Cocaine use, nationally in the blue, 5.4. Again, almost twice as much here in New Mexico at 10.3. And of course, ecstasy, greater than national level. Heroin use, 3.3, and this is for all ages from high school students. 3.3 nationally, 4% here in New Mexico. And for methamphetamine, which is showing a recurrence in many parts of the country, and especially here in New Mexico, 3.7 nationally and 5% in New Mexico. So these are show that we actually have a disproportional problem of adolescent substance abuse here in our students in New Mexico. Among high school student school-based health center users, and this was from information gathered by the Department of Health, 60% have used alcohol, 30% have used marijuana or other drugs, and 30% have been in a car with an impaired driver. Again, these may not be surprising statistics for you, but they are statistics that show us there's a special need in New Mexico to do something in an integrated way. Substance use increases risky behaviors. Adolescent substance abuse users are much more likely to be sexually active, engage in risky sexual behavior, which is quite a serious problem in our state, become pregnant, and contract sexually transmitted diseases. Risky sexual behavior during the last sexual intercourse among New Mexico adolescents, again, this is from the Youth Risk Behavior Survey, shows that drank alcohol and used drugs in the blue, 19.1%. So in fact, using alcohol and drugs increases the risk of risky sexual behaviors in our New Mexico adolescents. 42% did not wear a condom. I can't quite read the number on the top of the green, but did not use birth controls. It's about close to 80%, and did not use any form of contraception is about 14%. So we have a high level of risky sexual behaviors in New Mexico adolescents, and a portion of that is related also to alcohol and drug use. Substance use increases unintentional injuries and fatalities as well, a major contributor to leading causes of death among adolescents. motor vehicle accidents, homicides, suicides, and even first-time use increases the risk of unintentional death or injury. We know that 68% of emergency department visits by 12 to 17-year-olds involved the use of alcohol or drugs in 2008. And I believe this is from the national database put out by SAMHSA. And 31% of 15 to 20-year-olds involved in fatal crashes in 2008 had been drinking. So these, of course, are pretty alarming figures. It's something that we absolutely can do something about, and we believe that SBIRT is one of the evidence-based practices that can help with this. Substance use in school, well, it won't be a surprise to you that adolescent substance users are twice as likely to have poor grades and drop out of high school. We have a particularly high dropout rate here in New Mexico, more likely to get into fights at school, and substance use is also associated with other school misconduct and lack of effort and interest in our young people. There are also specific health concerns besides poor performance in school and risky sexual behaviors. There's also increased risk of liver disease, stroke, cancers, headaches, eczema, irritable bowel syndrome, peptic ulcers, asthma, sinusitis, and sleep disorders. And of course, there's also an increased risk of HIV and other sexually transmitted diseases. And as we're all too familiar with here in New Mexico, there's also increased risk of alcohol poisoning and overdose death, especially from opiates, as we've seen throughout New Mexico in the last few years. Binge drinking. Well, binge drinking is something that's often associated with college students, but in fact, we know that binge drinking is real for adult populations as well as for our adolescents. It's defined by the National Institute of Alcoholism and Alcohol Abuse for men who are adults as 5 or more drinks during a 2-hour period. For women and men over 65, it's 4 or more drinks during a 2-hour period. But for youth, it's a little bit different. Youth ages 9 to 13 is 3 or more drinks during a 2-hour period. This is binge drinking. Girls ages 14 to 17, 3 or more drinks. Boys ages 14 to 15, 4 or more drinks, again, within this 2-hour span. And boys ages 16 to 17 are considered binge drinking at the same as essentially as adult male levels, 5 or more drinks during the 2-hour period. So binge drinking is a serious problem throughout the United States, and New Mexico is no exception to that, and this causes serious health consequences. Adolescence and depression, well, 26.9% of adolescents reported symptoms of depression in the last 12 months, compared to 40.1% of current drinkers reported symptoms of depression, 43.4% of binge drinkers reported symptoms of depression, and 37.7% of current marijuana users reported symptoms of depression. 18.6% of binge drinkers actually attempted suicide during the past 12 months. And so we can see that this is a very serious problem for our adolescents and actually for their behavioral health and mental health status as well. Long-term effects. Well, this is a very important slide. Early initiation of alcohol increases the likelihood of future dependence. In other words, the longer that we can prevent our youth from initiating alcohol or substance abuse, the less likely they are to develop a substance use disorder in their adulthood. 47% who started drinking before the age of 14 developed an alcohol use disorder in their lifetime, compared to only 9% of those who started drinking after turning 21. So every year, every month, every period that we can prevent initiation of use of alcohol or other substances increases the likelihood that there will not be a substance use disorder in their lifetime. So this is something very worthwhile in terms of prevention for us to undertake. There's also data on cognitive functioning of the brain can be permanently impaired even if adolescence stops using. When I went to school many years ago as a neuroscientist, we actually thought the brain was fully developed when young people were had reached adolescence. We now know, because of research in the last 10 years, that the brain is not fully developed until the early 20s in young people. So the developing brain can absolutely be impaired by foreign substances coming in. The exact nature of that is there's much research going on in that. So what is the answer? Well, what is the evidence-based practices that are available to address this issue? And I believe that we all believe that is SBIRT, screening, brief intervention, and referral to treatment. And I'm going to tell you a little bit about this. This will be your first introduction to SBIRT, but probably not your last. So what is SBIRT? Well, it stands for screening, brief intervention, and referral to treatment. The goal is identification of at-risk substance users in non-substance abuse treatment settings, such as primary care, school-based health centers, and provision of appropriate services, and a delineation of an action plan about how to handle those individuals. And so this is SBIRT is a prevention and intervention strategy designed to address substance use problems at various risk levels. It identifies substance use problems using a public health approach, which is not something we've always done in this country when it comes to substance abuse, is to address it as a public health issue. It includes universal screening, immediate brief interventions, and a non-substance abuse treatment setting. Targets moderate, risky users, but also provides encouragement to abstainers and low-risk users, and provides referrals to specialty treatment for those with symptoms of substance use disorder and addiction. It's a recommended practice from the American Academy of Pediatrics and the American Medical Association recommend that pediatricians and other healthcare providers who work with children and adolescents conduct routine substance use screenings and brief interventions using motivational interviewing techniques, and then they'd be familiar with a network of treatment providers should an outside referral be necessary. And these are the elements that we're, in fact, going to help you, we'll go through with this presentation, but also in the next few months we'll help you with the training needed and contacts for all of these things. How substance abuse addresses student needs? Well, again, early intervention, can't stress that enough, is the best way to prevent substance abuse problems. It reduces alcohol and marijuana use, prevents initiation of substance use, offers convenience and confidentiality, and it's a good fit for adolescents in this case, especially in school-based health centers. Brief interventions with adolescents in school-based health centers. Well, this is actually a slide from the Institute of Medicine report about the general population. As you can see at the bottom of the triangle or the pyramid, the base, there's a large group of people, and especially this is true for adolescents, who actually do not use alcohol or substances of abuse, or a large group that are very infrequent users. And these are individuals that we would want to encourage to remain abstinent or congratulate them for infrequent use. But there's a whole large group in the middle where in fact substance use is mild or moderate, and these are individuals that could lead to developing severe substance use disorder. So the brief interventions can occur in schools, in the juvenile justice system, in pediatric clinics, in school-based health centers, mental health clinics, and drug treatment. And of course, on the top of the pyramid are those who need intensive treatment. Those are with the most severe substance use disorders. Organizational cost savings. Well, actually, SBIRT has been looked at and is ranked among the top 5 most beneficial and cost-effective preventive health services for alcohol by the U.S. Preventive Services Task Force. It's actually more cost savings than higher than screening for high blood pressure, for high cholesterol, for breast, colon, and cervical cancer, and for osteoporosis. And there's been studies showing that about $4.30 can be saved for every $1 spent on substance use early interventions. And if you think about that, again, back to that slide, is the longer you can prevent somebody from initiating, the less likely they are to develop a substance use disorder in their adulthood. Convenience and confidentiality. Well, providing SBIRT in your school-based health center provides the convenience of the school with the confidentiality of your clinics, which is one of the great strong points of school-based health centers. Students willing to discuss substance use with a knowledgeable healthcare provider and bring discussion of substance use into the healthcare setting rather than separated into just behavioral health. It's a good fit for adolescents, we believe, also, because adolescents, as you know, are ambivalent regarding changing their substance use. They have a great desire for autonomy, and as all of you know, they often resist authority. Self-guided structure of SBIRT does not force them to admit having a problem, but instead allows them to develop what we call an action-oriented goals while avoiding any confrontation. And avoiding confrontational situations, especially with our adolescents, is very critical to be successful in changing behaviors. What is SBIRT? This is one of the questions that you need to answer if you're, in fact, getting continuing education credits. What is SBIRT? A, screening, brainstorming, referral to treatment. B, screening, brief intervention, referral to treatment. C, screening, brief intervention, required treatment. D, none of the above. Would anybody like to answer these, please? You can type in an answer, or you could unmute your phone. Okay, we have Julie saying B, screening, brief intervention, referral to treatment. Well, you get an A, Julie, thanks. B, yep. Tiffany says B. And our last, Megan, B. Very good. And again, these questions are requirements as part of the continuing education credit process. So I know this seems a little simplistic, but these are the requirements. And thank you for all getting it right. Obviously, the slides at least are doing a good job. So the SBIRT protocol we have in mind for the New Mexico School Department of Health school-based health centers are the following. All school-based health center providers, both behavioral health providers as well as primary care, are going to receive SBIRT and motivational interviewing training on local and state referral resources, and also a kit, essentially, of electronic tools and materials to support SBIRT practice. And again, this is all made possible by both our collaboration with the Department of Health, but also by their generous grant from the Conrad Hilton Foundation. Oh, sorry, this one's a little messed up. SBIRT versus current practice. So what is currently going on in our school-based health centers, and what is SBIRT, and how will that be different? So providers often deliver some of the components of this model already, but SBIRT is an evidence-based for delivering all the components of the model in a combination. So universal screening using a standardized tool, and we'll talk what that is, a little bit about what that is. Delivery of services based on screening score and assessment. Patient-guided brief interventions using motivational interviewing, which is a very interesting and successful technique, but very different than some of the other approaches that have been used in the past. And referral to treatment when indicated, especially intensive outpatient treatment for those who have serious problems. Current practice in New Mexico school-based health centers, screening with the Student Health Questionnaire. Well, the Student Health Questionnaire was developed as a global health screen used by the New Mexico Department of Health school-based health centers once annually. So every student who comes into a school-based health center takes a Student Health Questionnaire. This has been adapted from the American Academy of Pediatrics Bright Future recommendations. And in their foresight, those in the Department of Health who developed the school health questionnaire included within this a screen, a universal screen called the CRAFT, C-R-A-F-F-T, which is in fact a validated tool to screen for adolescent substance abuse. And this is one already in the school health questionnaire, and it's something we're going to talk a little bit more about. However, there is wide variation in provider practice. In 2012, a school-based health center provider survey showed that only 1 in 10 providers were aware of the craft in the school health questionnaire. Most providers do not know how to use the craft, and many providers are unaware of how to conduct brief assessments and treatment following a positive substance abuse screen. So there's quite a bit of variation in terms of provider practice within the network of school-based health centers. As I said, part of this follow-up that we did, that the Department of Health did in 2013, was to do focus groups with providers from school-based health centers and try to find out what was going on and why so few knew how to use the crafts and the various techniques. So essentially what was found was that there was really no developed standard of care in place for all of the school-based health centers related to substance abuse. There's variation in how providers did assessment or assessing of individuals who had problems. And providers indicated they needed a tool to help them with both the assessment as well as understanding the screening. And one of the universal problems, not just here in New Mexico, but it's particularly acute in New Mexico, is few referral sources to providers are aware of. And that's something that we hope to help all of you identify better. The network of behavioral health providers on the outside that young people can be referred to when they have serious problems. Well, what does all this mean? Well, substance use services are being provided in school-based health centers, but not in a combination following the evidence-based SBIRT model. Providing the standardized SBIRT protocol may make clinicians more effective at helping their students with their substance use problems. Benefits of the standardized tool. Well, provides an evidence-based algorithm for provision of appropriate services, and I'll show you that in a minute. Takes the guessing game out of identifying problems of substance abuse, who has a serious problem, who doesn't. Use of standardized screening tools results in higher detection of problems of substance use and is in fact known as a best practice. And use of a new New Mexico CHISPA, which is a brief assessment tool developed here in New Mexico for this program, will provide additional information for providers. So although the craft gives you a good screen, it doesn't tell you as much specificity as the CHISPA will. And again, this is a brief assessment tool developed at Envisions with the Department of Health and in CASA. Review of SBIRT pieces to be implemented. Well, the plan is to implement the full SBIRT model in all of New Mexico's school-based health centers supported by the Department of Health. Screen. The screen, as I said, you already have in your school health questionnaire, and that's the craft. A positive craft, and it consists of 6 questions, the craft. A positive craft will have initial brief assessments. Newly created tool is called the CHISPA, and I believe it's Spanish for spark, and the acronym stands for cocaine, heroin, synthetic pot, and alcohol. It's standardized and informs the initial assessment. Brief intervention will be, in this case, mostly motivational interviewing, and then the RT, referral to treatment. More developed referral resources is what the plan for implementation is. The CRAFT screening tool, as I said, it's a validated screening tool to use with adolescent patients, originally developed at Boston Children's Hospital, and now it's been validated in a number of different places as a very appropriate screening tool for adolescents. Because it screens for both alcohol and other drugs problems simultaneously, it is especially handy for providers. The CRAFT consists, as I said, of 6 questions. A positive CRAFT means the students should be assessed for alcohol or drug use or dependence. And again, this is all endorsed by the American Academy of Pediatrics. So what does the CRAFT stand for? Well, of course, every acronym we have in the field of behavioral health has to stand for something. And so the CRAFT stands for have you ever, and this is lifetime, have you ever, C, ridden in a car driven by someone who was high or intoxicated. R, have you ever used alcohol or drugs to relax? A, have you ever used alcohol or drugs while you were alone? F, have you ever forgot things you did while using alcohol or drugs? The other F is have family or friends ever told you to try to cut down on your use of alcohol and drugs? And T is have you ever gotten in trouble while using alcohol and drugs? And as you can see, these are kind of broad questions. They don't give you very much specificity, but since this is a validated tool, in fact, answering the yes to a response is counted. However, a CRAFT score of 0 or 1 answers is considered a negative screen. And in these cases, the individual should be given positive feedback, brief advice, and encouragement to continue the kinds of behaviors they were exhibiting. A CRAFT score, however, of 2 to 6 is considered a positive screen. And it needs then, in fact, to necessitate assessment for acute dangers and signs of addiction, and to provide brief intervention and consider the possibility, depending on the severity, of referral to treatment. As you can see, the CRAFT has been studied extensively, and here's part of the predictive value of the CRAFT. On the one axis is the CRAFT score, on the other axis is the diagnosis of abuse or dependence for substance use disorder. And as you can see, from score 2 to score 6, there's about a 50% up to almost 100% predictability of a CRAFT score predicting drug abuse or dependence. And so this is one of the validation studies that had been used. So this is a very effective screening tool as far as predictive value goes. So after a positive CRAFT screen, a brief assessment for acute dangers and signs of addiction is necessary. The SBIRT model calls for assessment. The CHISPA model that has been developed is a brief assessment tool developed in New Mexico to help standardize this assessment. It's designed to automatically follow a positive CRAFT. So when there's a 2 or more above score on the CRAFT, this automatically takes you to the CHISPA assessment tool. It's an electronic tool, helps standardize information gathering. It assists providers in clinical decision making. It provides the specificity that the CRAFT does not. CHISPA, again, cocaine, heroin, IV drug use, synthetic pot, and alcohol. The CHISPA brief assessment tool identifies what substances are being used. In New Mexico, we have high rates of early alcohol and marijuana, as we showed in those other slides, high rates of cocaine, meth, ecstasy, and opiates. And it actually asks those questions in this brief assessment. What's the specificity of the drugs the adolescent is using? A very critical component of this is the frequency. So this actually asks the students how frequently are they using these drugs, and signs of dangers. So it actually explores things like blackouts, binging, emergency room visits, combining alcohol with downers, IV drug use, etc. It also asks the students about past efforts to quit or to cut back and what was the success of those. Benefits of using the CHISPA brief assessment tool is, again, specificity beyond the CRAFT at initial contact. It uses a 3-month time frame, a 3-month window, versus the broader time frame for the CRAFT. The CRAFT is have you ever. The CHISPA is in the last 3 months, what substances have you used, what the frequency of use has been, and what specific signs of danger or addiction have happened. Appropriate for informing clinicians' initial assessment with higher risk New Mexico school-based health center populations may be useful at all school-based health center follow-up visits as well, the CHISPA, and it helped make judicious use of the limited behavioral health resources in our state. Of course, this is a nationwide problem, limited behavioral health resources, but it's particularly acute here in New Mexico. So here's the algorithm essentially for the New Mexico School-Based Health Center's SBIRT algorithm. So the students get screened, again, at age 14 or older, with the CRAFT, which is embedded in the school health questionnaire. If you get a negative, on the right side, if you get a negative 1 or 0 response, you reinforce continued good choices and good behavior and safety of these behaviors. If you get a positive score on the CRAFT, 2 or more, it automatically goes to the CHISPA assessment tool, which helps determine the level of concern, signs of danger of addiction, substances being used, and again, very important, the frequency. So when you see the CHISPA and the output of it, it summarizes whether you have lower concerns, and that would solicit a brief intervention and maybe follow up as needed. Moderate concern means that there's a higher level of substance use. Brief motivational interviewing by school-based health center providers, possibly multiple sessions within the school-based health center. Again, one of the things that we're looking to use as a standardization is one of the HEDIS measures, which calls for the first session at the time of the assessment and 2 additional sessions within 30 days after the initial assessment. Highest concern students, again, using your judgment as school-based health center providers, you can rely on your behavioral health expert to decide whether or not this is something that can be handled in-house with multiple sessions and different kinds of interventions in addition to motivational interviewing, or whether this is serious enough that you need to in fact refer the student out for more intensive treatment in another facility. So here's your next question. What screening tool is part of the standardized student health questionnaire used by all New Mexico Department of Health school-based health centers? A, the audit, B, the CAGE, C, the CRAFT, or D, the DAS? Very good, everyone. Thank you. It is the CRAFT. I've only said it 400 times this morning, but yes, it's the CRAFT, a validated tool, again, as I told you, originally from Boston Children's Hospital and now used in a variety of settings with much validation stuff out there. Brief interventions for adolescents. Well, what are those? Well, they're brief negotiated interviews. They're a type of motivational interviewing. Many of you are probably not aware that motivational interviewing as an intervention technique for substance abuse was actually really invented at the Center for Alcoholism, Substance Abuse, and Addictions at the University of New Mexico, where I work. Not during my time there, but many years ago by Bill Miller and some of his colleagues. And so this is really a homegrown intervention, which is now very popular and used all over the world. May involve multiple sessions, which is important. And MI training, although we're not going to be doing that today, you are going to be getting a standard MI training, which involves a didactic training session as well as coaching, at least 3 coaching sessions by our MI trainers who will go through some of the sessions that you've provided on MI interactions. So I'm not going to go into what the MI is, but it really relies on these principles, and they're called the OARS principles. And they're open-ended questions, affirmations, reflective listening. Again, that's a very important component of motivational interviewing, and summaries. These are the basic interaction skills used early and often in motivational interviewing approach. Open-ended questions, such as invite youth to tell their story in their words. What can you tell me about blank? Help me understand what you get out of using these drugs. What do you think will happen if you cut down on these use of these drugs? What have you tried before? What do you think about fill in the blank? So again, these open-ended questions are not an interrogation, they're more of fill in the blank for the students. Affirmation, recognize strengths of clients and patients and acknowledge the behaviors that lead in the direction of positive change. I appreciate that. That was a very good suggestion. You handled yourself well in that situation. Again, this is having a conversation with the adolescents as opposed to giving them a lecture. Reflective listening. This is one of the hardest uh, parts of, I believe, of MI for practicing clinicians who've already been trained in various ways to adopt. A primary skill in outreach and engagement with all clients and patients, whether they're adolescents or adults, is learn to think reflectively. And that means things like, it sounds like to me, after they say something, or so you feel that, and again, it's repeating what the individual has said. Again, you've listened to them and now you're reflecting back to them what you heard. I think I hear you saying that. And these help instill more confidence that you're actually listening to the adolescent and provide, rather than just being didactic and providing direction. Summaries. Summaries are very important. So you've gone through the other parts of ORS, and so to ensure clear communications, and this can also be a stepping stone to actually enact behavioral changes. You might say things like, and again, you'll get more training on this, but this is just to give you a flavor. Let me see if I understand you so far. So you're summarizing. Here is what I heard. Tell me if I missed anything. On one hand, on the other hand, and again, these summaries help to provide an overall basis for this interaction and this conversation that you're having with the adolescent. Provider role in enhancing motivation. Well, it's critical. You can gauge your students' state of change. Are they ready for change? Is there any possibility? And you can respond accordingly. The key is not to be confrontational in the interviewing. There's much research that's been shown that confrontational interviewing is counterproductive. And again, the use of motivational interviewing techniques, these OR principles, which you'll receive more training on, is a very useful and insightful approach. Multiple sessions of brief intervention may be necessary. Adolescents who agree to make behavioral changes in their lives should be given a follow-up appointment to discuss the results of their efforts and be praised for any progress they make, no matter how small. And many of you already do that anyways in your practices. Multiple sessions with students can help provide the provider facilitate and monitor the behavior change. And again, multiple sessions, perhaps multiple assessments with the CHISPA can also help document behavior change over the course of time. Referral to treatment. Well, unfortunately, there will be a small percent of youth who will need to be referred out to alcohol or drug treatment because of the severity of the problems you've discovered with your assessments. However, you will most likely need to get parents involved in this part of the referral process. The goal is school-based health centers should have at least one current referral agreement with an accessible certified treatment provider and understand available programs and services that are provided and the referral procedure. The referral to treatment is one of the things that's often forgotten about SBIRT, and it's one of the critical things for a small percentage of young people and adults who actually need a warm handoff to a more intensive treatment program with a smooth referral process. And we've been working with a number of the managed care organizations who are administering Centennial Care, working with their behavioral health network providers to try to identify who are the appropriate treatment providers in all the areas that school-based health centers are serviced by. Well, we also recognize that there are many barriers. Much of this information came from the 2013 Department of Health Provider Survey. The main barriers to discussing, treating, and referring for treatment substance use reported by New Mexico school-based health center providers are: do not know where to refer students to treatment. 73% of the providers said this was a major, major barrier. And this is something that we hope, again, with support of the Hilton Foundation grant, to help kind of lay down the pathways for those referrals, for a seamless referral to treatment, for this, what I call the seamless handoff to individuals into the behavioral health treatment system. Confidentiality concerns regarding parents were very high on the list of barriers by providers. Time constraints. You're all busy. Everybody's busy. These are time constraints in healthcare are probably one of the number one barriers for delivering the most extensive care that's needed. But there was also a report of lack of an algorithm, which are now, we believe, we've started to address by developing the New Mexico School-Based Health Center SBIRT algorithm. Lack of an assessment tool. Many providers didn't have, in fact, an assessment tool and relied on other approaches to figure out what the level of severity was. We've now developed the CHISPA assessment tool, which we've been out in the field and validated it on a number of ways, and we think that this is actually going to be very good for the New Mexico school-based health centers, and we hope to, in fact, for pediatric practices in other places as well. And a very big concern or barrier for providers was that we lack the experience. And one of the things that we hope we'll be doing by this implementation process is to be training you on SBIRT, training you on motivational interviewing, helping you understand the referral to treatment process, and giving you tools and materials to help increase your level of expertise in this area. So here's one of your questions again. I think this is your last one that you need to answer. OR stands for open-ended questions, affirmation, reflective listening, and summaries. A. B. Open discussion, ask, reflect, summarize. C. Order, attack, retreat, subdue. Or D. None of the above. Okay, thank you, everyone. Our class gets 100% for today. So implementation support. So I know this sounds a little grandiose. Some of you might be rolling your eyes going, oh, yet another thing we're going to have to do on our own. We're hoping to supply implementation supports to each of the school-based health centers. Again, as part, this is the New Mexico School-Based Health Center implementation team. And there's a number of us involved in this project, as I said. Administrative support. Ensure that practitioners gain the skills required to conduct SBIRT. And we hope this training and some of the other trainings that we'll be giving you give you better insight and experience into what this is. Uses developed data systems to support implementation evaluation. Again, we've developed the CHISPA brief assessment tool as an electronic tool that it's automatically inserted into the school health questionnaire after a positive CRAP. Also can be used on its own as a separate app on iPads. And for New Mexico Department of Health, SBIRT and electronic school health questionnaire with CRAFT and CHISPA are going to become a priority in the future. As I said, this is going to become one of the standards and benchmarks for school-based health centers in New Mexico. The implementation teams and champions. Well, Department of Health, New Mexico Department of Health, working with the University of New Mexico, both here in Envisions, where we're speaking to you from today, as well as CASA, have helped to define what this implementation strategy should look like. And we didn't do that in a vacuum. We got lots of input from providers and from other stakeholders in the field. We have designed SBIRT so that it is integrated into the existing system. And we have selected the electronic screening and assessment tools to support this SBIRT implementation. It is important, however, for each organization to identify a champion to support SBIRT, because there will always be questions. There will always be needs to be a point of contact so that we can answer questions and do appropriate technical assistance when needed. Training and coaching. Well, this presentation provides just an introduction to SBIRT and the New Mexico School-Based Health Center project. This will be followed by training by motivational interviewing experts and coaching by those experts over a 3-month period for individuals who've received the MI training. It's important that these skills be practiced and mastered on the job with the help of a coach. Identify an individual at the school-based health center, again, to serve as an SBIRT champion. This person should develop expertise in all aspects of SBIRT. And we will, in fact, be providing ongoing technical assistance to all the school-based health centers during this implementation process. The goal is to link school-based health centers to substance abuse treatment providers. This seems to be one of the biggest areas where there's a challenge, both because of the lack of behavioral health providers in our state, as well as a smooth, seamless system for referrals and warm handoffs. So we are going to assist you in meeting substance abuse treatment agencies in your area, describe the referral requirements, because that can always be, always cause somebody to fall through the cracks, and identify contacts at substance abuse treatment programs for questions and consultations. Again, these linkages are going to be very important for the referral to treatment process. So, SBIRT for New Mexico Department of Health School-Based Health Centers. Simple, usable format and tools to deliver SBIRT. This is our goals. Accompanying resources for school-based health center providers. We have reference books, we have materials, we have DVDs, we have electronic apps for you. We'll be providing iPads with the apps on them and for students, and materials for students as well. School-based health center providers supported by tools, training, technical assistance, quality assurance and quality improvement, referral sources, and consultations as needed. So that's pretty much the end of my presentation. I wanted to introduce you to at least the names and contact numbers for the New Mexico School-Based Health Center Implementation Team project. Daisy Rosero is the actual program manager, and you will become very familiar, if you are not already, with her name and her email and her telephone number. I'm Tim Condon at UNM CASA. Mary Ramos is MD, MPH. Dr. Ramos is a pediatrician. She's here at Envision in the Department of Pediatrics. She's also is a provider, a pediatrician is a provider at an elementary school, school-based health center. So she actually not only talks the talk, she walks the walk as well. And Kristen Oreskovich at the Department of Health, Office of School and Adolescent Health is our main contact at the Office of School and Adolescent Health, who oversees school-based health centers. And Erica Partridge Griffin works with me at CASA, and she'll be contacting you, providing things like setting up schedules for trainings, for your coaching calls, and for another different information type things. And I believe that is all I have to say. Thank you for your attention today. I hope this was helpful and useful. And if there are any questions that I could answer, I'd be happy to do that.
That would be a negative. Sound good, Julie.
And these are the people at Envision, Quality Improvement Staff Directory. And you can see that Daisy's there, Mary's there, a number of other people as well. Do you have more on here, Kevin?
No, we just have our thank you slide at the end. Did we have any other questions this morning or comments?
Thanks. Hi, this is Julie. I just wanted to say thank you very much for a great presentation. And
Thank you.
I'm looking forward to the motivational interviewing training.
I love to hear that from primary care practitioners. I've had discussions with Mary Ramos, who's a pediatrician, and when we start talking about MI, she said, it's just not the way I do clinic. I, identify the symptoms, figure out what the problem is, and give very specific directions to the students. And I said, well, you're going to have to change your way of thinking and be more reflective. And Mary's actually been a very good example of how this actually can work. And as you probably know, Julie, that motivational interviewing isn't just for substance abuse, behavioral health. It's also being used in a number of places for changing other kind of health behaviors such as obesity and overweight and eating behaviors. So this is something that would be useful in all aspects of your practice.
Yeah, it's true. And we did learn in medical school, we did learn about asking open-ended questions, but that was about it as far as MI goes, I think.
Okay, well, that's a start. Congratulations.
Yeah.
You did the O in ORS.
Right.
Any other questions? Okay, if not, you'll be hearing from us again soon. I believe some motivational interviewing sessions will be taking place this week and next week. And I believe I'll be giving another SBIRT presentation to those who were not on the call today.
That I'm not sure of. I know we did record the session today.
Perfect.
So we do have that available.
Okay. Well, thank you all for your attention, and I look forward to working with all of you on this project. I'm a research scientist by training, and so I very rarely say that we're going to get a result or one result, but because of the level of adolescent substance abuse in the state, I really believe that implementation of this SBIRT model, we are going to have impact for the young people of New Mexico. So thank you for what you do, and thanks for your